Well, good afternoon, and welcome to our second ACCP AST Resident Research Webinar of 2026, supported by our ACCP Transplant PRN as well as AST's TXP COP. My name is Crystal Vo, and I'm a current PGY1 resident at Mayo Clinic in Arizona. And it's my pleasure today to moderate today's webinar alongside with Samantha Shirk, who is also a PGY1 resident at Mayo Clinic in Arizona. We are honored to have our residents here today to learn about their research. Friendly reminder that this is one of 3 webinars and all are available for CE credit. An email will be sent out to attendees at the end of the webinar to obtain CE from Rush University. Before we get started, I just want to remind everyone to come with a few quick notes. For our audience members, please ensure that your microphone remains muted for the duration of today's presentation. The mute button is located in the lower left-hand corner of your screen. If at any point during the presentation you have a question for the speaker, please submit your question by using the chat functionality at the bottom of your screen. Please send your questions directly to either Samantha and I to minimize possible interruption. We will take questions at the completion of the presentation. Today's webinar will be recorded and posted on the ACCP Transplant PRN YouTube channel. If you do experience any technical difficulties during this webinar that are not fixed by logging out and refreshing your internet connection, please make sure that the moderators are aware through the chat functionality as well. Now, without further ado, I will turn it over to Samantha to begin our webinar.
Thank you, Crystal. So for today's presentations, we will be focusing on optimizing antimicrobial prophylaxis in our cardiothoracic infectious disease area, as well as a study looking specifically at the utilization of transplant pharmacists. For today's webinar, our objectives are to evaluate the emerging research findings from pharmacy resident projects in solid organ transplantation and their implications for contemporary clinical practice, as well as assessing antimicrobial prophylaxis strategies in cardiothoracic transplantation, including effects on infection risk, adverse events, and transplant outcomes. And lastly, we will be identifying opportunities to optimize transplant center practices based on presented data, including areas for future research. For this webinar, as a disclosure, all individuals in control of content have no relevant financial relationships to disclose, and presentations may include discussion of off-label medication uses. I do have a QR code here to our research toolkit created by AST and ACCP Transplant PRN. It's great for new residents, and it just provides you with some additional tools regarding to research. But we will now be hearing from Melanie Kwok, who is a PGY2 solid organ transplant pharmacy resident at UC San Diego Health.
Hi, everyone. Thank you for having me. Samantha, if you don't mind. Perfect. I have control of the slides now. Thank you for joining. My name is Melanie. I'm one of the solid organ transplant PGY2 pharmacy residents here at UC San Diego Health. And today I will be presenting my research project titled Evaluating Outcomes of IV Linezolid versus IV Vancomycin as Perioperative Antibiotic Prophylaxis in Heart Transplant Patients. Thank you so much to my co-authors, Linda, Mark, Nina, Victor, Jenny, Nancy, and Ashley for their collaboration with me on this project. We don't have any financial relationships or conflicts of interest to disclose for this project. And here's just a brief overview of some abbreviations that you may see throughout the presentation. Just a brief overview of my presentation. We're going to be discussing some background before jumping into the study, the results, and the conclusions. Starting off with the background, perioperative antibiotics are started prior to or at the time of transplant surgery within 60 minutes of the surgical incision and continued for at least 48 hours in heart transplant surgery to minimize postoperative infections. Transplant surgery is unique in that the risk of infection is not only for surgical site infections, but also donor-derived infections from the graft itself. In heart transplant surgery, the risk of surgical site infection ranges between 4 to 19% per the IDSA, with the most common causative pathogens being coagulase negative staphylococci, MRSA, enterococci, followed by gram-negative pathogens, Enterobacteriaceae, Pseudomonas, Stenotrophomonas, and Candida. Patient-specific risk factors for surgical site infections include increased age, obesity, diabetes, prior cardiac procedures, prior ventricular assist devices present, prolonged mechanical ventilation, recipient or donor colonization prior to transplant, and reoperation or retransplantation. Prior to the IV fluid shortage, our standard perioperative antibiotic protocol at UC San Diego Health was to use IV cefuroxime 1,500 milligrams in conjunction with IV vancomycin 15 mg per kg. The optimal antimicrobial agents for perioperative prophylaxis and heart transplant is controversial and center specific. But following the IV fluid shortage in September of 2024 in the aftermath of Hurricane Helene, our center updated the perioperative protocol to allow for the use of linezolid in place of vancomycin in order to conserve IV fluids. So we switched out the vancomycin 15 mg per kg to use linezolid 600 milligrams in conjunction with the cefuroxime 1,500 milligrams, and all antibiotics were still continued for at least 48 hours post-transplant or longer at provider's discretion. Jumping into some information about this study now. We conducted a single-center retrospective cohort study that included heart transplant recipients at UC San Diego Health between January 1st, 2023 and July 31st, 2025. A total of 235 heart transplant patients were screened for inclusion based on information available within the UNOS database. Patients who underwent multi-organ transplants, patients who required renal replacement therapy prior to transplant, and those who received redo heart transplants were excluded from analysis. Outcomes of interest were based on 4 categories: kidney-related, hematologic, ICU-related, and infection-related outcomes. There were changes in renal function, as well as incidence of acute kidney injury defined by the 2012 KDIGO criteria, incidence of thrombocytopenia and leukopenia, time to extubation, overall ICU length of stay, as well as post-op infections and post-op C. diff. Jumping into some of our results now. A total of 190 patients were included in the analysis, with 163 patients in the vancomycin group and 27 patients in the linezolid group. The groups were both similar in age, with the median age being 60 in the vancomycin group and 64 in the linezolid group. Both groups were predominantly consisted of white males. A total of 9 patients in the vancomycin group required ECMO support before transplant, compared to 2 patients in the linezolid group, and more patients in the vancomycin group also required mechanical circulatory support at 62%, most often with an intra-aortic balloon pump, compared to just 41% of the linezolid group who required MCS support. In addition to more patients requiring MCS support in the vancomycin group, it also had more patients requiring ICU level of care prior to transplant at almost 50%, compared to 37% of the linezolid group. Both groups had more DBD or donation after brain death donors compared to donation after circulatory death donors. For our outcomes, the groups were matched using propensity score matching, and no statistically significant differences were observed in the kidney-related outcomes between the 2 groups. Approximately 50% of patients in each group experienced an acute kidney injury or AKI. In the vancomycin group, most AKIs were stage 1, whereas in the linezolid group, there was a more even distribution across stages 1 through 3. Changes in serum creatinine were also similar between the groups at postoperative days 7, 14, 30, and 90. And although a greater proportion of patients in the linezolid group required renal replacement therapy following transplant, approximately 15% of the linezolid group did, this difference did not achieve statistical significance. For our hematologic outcomes, both groups had similar incidence of anemia and thrombocytopenia, as well as similar percent changes in white blood cell count. However, a statistically significant difference in platelet count was observed at postoperative day 7. The median platelet count was 175,000 per microliter in the vancomycin group compared to 141,000 per microliter in the linezolid group. Although this finding is consistent with the known risk of thrombocytopenia associated with linezolid use, the clinical significance of this difference remains unclear. For our infection-related outcomes, the most common indication for extending or broadening antimicrobials in the post-transplant period was for empiric treatment. Other common indications were pulmonary infections, genitourinary infections, mostly UTIs, and donor-related infections requiring the extension of antibiotics pending donor cultures or recipient cultures resulting. There was 4 patients diagnosed with C. diff infection post-transplant, and all were in the vancomycin group. No patients in the linezolid group had C. diff post-transplant within 6 months. Lastly, for our ICU-related outcomes, there were more patients in the linezolid group that required mechanical circulatory support post-transplant, either with ECMO or an intra-aortic balloon pump compared to the vancomycin group. Both groups did have similar number of days requiring ICU level of care post-transplant and overall hospital length of stay. There was a total of 3 hospital readmissions between the 2 groups, all for infection-related chief complaints. 2 patients were from the vancomycin group for bacteremia and positive cultures, and 1 patient in the linezolid group for an UTI. So in conclusion for our project here, the study evaluating outcomes of linezolid versus vancomycin as perioperative antibiotic prophylaxis in heart transplant, the results show that the linezolid can be used as an alternative to vancomycin as perioperative prophylaxis. However, it is associated with an increased risk of thrombocytopenia in the early postoperative period between post-op day 0 and post-op day 7. There are some limitations to this study, being that it's a single center retrospective study with a small sample size, particularly in the linezolid group, and the evaluated outcomes were limited by information available within formal chart documentation. For future directions of our project, we plan to further evaluate the use of linezolid as perioperative prophylaxis within our lung transplant population, also looking at associated kidney, infection, and hematologic outcomes as well. And with that, it concludes my presentation. I'm happy to take any questions. Thank you, everyone.
Thank you, Melanie. Does anybody have any questions for her? Okay, I do have one. So for your hematologic goal outcomes, generally linezolid-induced thrombocytopenia would be expected to take 7 to 14 days of therapy to develop. Did you assess how often these hematological HTRs received linezolid beyond the recommended 48 hours, or find any prior evidence that a more rapid onset of toxicity may occur in this population?
Thank you. That's a great question. So for a majority of our patients that were on linezolid, if antimicrobials were continued longer than 48 hours, they were actually most often transitioned to alternatives to escalate therapy, mostly with vancomycin and SOSIN in combination at first. So we can go back and look a little bit at that. In terms of the earlier onset, I think that there's a lot of confounders definitely to this change in platelet count in this early postoperative period, given that these patients are early post-op. Some of them are requiring renal replacement therapy, most likely on CRRT in this post-op period or on ECMO and things like that. So I think there's definitely multifactorial contributing to this decrease in platelet count.
Thank you, Melanie. Does anybody have any final questions for her? Okay. Well, I'm not hearing any. Thank you, Melanie. We will now be hearing from Janae Dean, who's a PGY1 pharmacy resident at the St. Joseph's Hospital and Medical Center in Phoenix, Arizona.
All right, hello everyone. Like Samantha said, my name is Janae and I'm a PGY1 at St. Joe's in Phoenix. And today I'll be presenting on my research, which evaluated the effectiveness of short course molecule prophylaxis for prevention of hyperammonemia syndrome post-lung transplantation. So a little bit about the institution. We are a nonprofit teaching hospital with about 600 beds. And of note, we are home to the Norton Thoracic Institute, which is one of the largest lung transplant centers in the US. So a little bit of background about what hyperammonemia syndrome actually is. So this is an encephalopathic condition that's characterized by altered mental status with markedly elevated ammonia levels in the absence of liver dysfunction. And this is a result of a donor-derived infection caused by molecule bacteria, specifically ureaplasma and mycoplasma species. This is pretty rare. We only see this occurring in about 1 to 5% of lung transplant recipients. And it's a pretty quick onset of about 1 to 2 weeks post-procedure, but this does have high mortality rates ranging from 30 to 75%. Prior literature, specifically looking more at Northwestern Medicine's protocol, involves the donor receiving levofloxacin 500 milligrams Q12 hours and azithromycin 500 milligrams Q24 hours after donor acceptance. And then at the time of lung transplant, they will perform a bronch and then send that BAL fluid for molecule testing. They'll then continue those antibiotics postoperatively in the recipient. And if the PCR comes back positive, they'll continue the prophylaxis for a total of 2 weeks. And if that PCR is negative, they will discontinue that. So although this has been shown to be a pretty effective protocol, there are potential challenges for widespread limitations. Specifically, antibiotic administration to the donor is not always guaranteed, especially in cases of donation after circulatory death. Additionally, not all centers have access to molecule PCR testing, and this test can take approximately 3 to 5 days to return, at which case your patient has now already been on antibiotics for 3 to 5 days. So here at St. Joseph's, we follow a different protocol. So we do not perform any routine donor or recipient screening for molecules. And instead, we start all of our lung transplant recipients on levofloxacin 750 milligrams Q24 hours for a fixed short duration of about 3 days. We also start our recipients on azithromycin at a low dose of 250 milligrams 3 times a week for bronchiolitis obliterans syndrome prophylaxis. So this protocol has not been formally evaluated, so that was really the objective of this study, was to determine the efficacy of this protocol in preventing HS. This was a single center retrospective cohort study. We looked at patients from January 1st of 2016 through June 30th of 2024, and we included all lung transplant procedures at SJHMC within that study period and did not exclude any patients. Our primary outcome looked at the incidence of HS within 45 days of transplant or any other donor-derived molecule infection within 6 months of transplant. We defined proven HS as laboratory confirmed molecule detection by either culture or PCR, in addition to having a compatible clinical presentation, so having that elevated ammonia level. For possible HS, we defined this as one of the following. So either a peak ammonia greater than 150 with a compatible clinical presentation and no alternative cause of hyperammonemia, or a peak ammonia greater than 70 and molecule-directed antibiotic therapy, Or lastly, death within 45 days of lung transplant that was not attributable to another cause, with these patients either having elevated ammonia or just absence of ammonia testing. We had a couple secondary outcomes. One of them was comparison of ammonia testing and peak ammonia levels by Public Health Service criteria donor status. So this chart is really here for your reference, but some things that would place patients into this higher risk category would be IV drug use or risky sexual practices. And the reason that this matters is that patients that fall within this PHSC risk criteria are more likely to have molecule respiratory colonization, which leads to increased risk of HS in the recipient of those lungs. We also looked at adherence to levofloxacin prophylaxis, specifically if this was started within 72 hours of transplant. And we also looked at the safety of levofloxacin, so looking at QTCs that were greater than 450, as well as peak QTCs within 4 days post-transplant, as well as how many patients were discontinued on this due to elevated QTC. So diving into our baseline characteristics, we had a total of 935 lung transplants within the study period. Our median age at transplant was 65. Most of our patients were male and white. For our transplant characteristics, over 98% were bilateral transplants. The primary transplant diagnosis was restrictive lung disease. Most of our patients, about 86%, were started on basiliximab as their induction regimen. And I did want to point out that we had 21% of our patients receive lungs from a PHSC donor. So for our primary outcome, we found no proven or possible cases of HS or other molecule infection within our study period. So as a reminder, we looked at lab data. So there was only one molecule test ordered, and this was over 3 years after transplant, and it was negative for both ureaplasma and mycoplasma. We had 16 patients who died within 45 days of transplant. Looking at those causes of death, none of them appeared consistent with HS. And we had a total of 168 patients who received ammonia testing for altered mental status. And of that 168, only about 5% had one or more levels greater than 70. So of those 8 patients who had levels greater than 70, 3 of those had acute liver dysfunction. So that is what we chalked up the elevated ammonia to. 5 did not have liver dysfunction. However, all values fell below 150, and 4 out of the 5 had ammonia that returned to normal prior to discharge. These patients were also not started on any new molecule antibiotics, and all were discharged and survived to 45 days. We also took a look at positive PHSC donor status and that frequency of ammonia testing and levels, and we found no statistical difference among patients who received positive, higher risk lungs from these donors compared to patients that received low risk lungs. So overall, we had really good adherence to levofloxacin prophylaxis at 95.4%. Of the patients who were not started on levofloxacin, over 60% had a reported allergy to fluoroquinolones. And overall, 99.9% of our lung transplant recipients received at least one molecule active antibiotic within 72 hours post-lung transplant. And that is when we included doxycycline, which was an alternative to levofloxacin, as well as azithromycin. And when it came to our safety profile, we did not see that levofloxacin was associated with an increased QTC compared to those patients who did not receive levofloxacin. And 8 of our patients had early discontinuation due to QTC prolongation, which we know is multifactorial. So the main findings of this study is that short course levofloxacin appears safe and effective for HS prevention. Short course prophylaxis can maximize protection in the highest risk period post lung transplant while also minimizing overall antibiotic exposure. And ammonia testing frequency and peak levels were very similar amongst lung transplants who received PHSC positive versus negative lungs. A couple strengths that I want to highlight is that this study was conducted at a large lung transplant center with a high proportion of PHSC donors over a 10-year period. And this was really the first study of its kind to evaluate the effectiveness of universal short course prophylaxis for HS prevention. A couple limitations, though. This was single center and retrospective in design. We cannot definitively prove that no HS cases occurred, although we did utilize multiple methods for assessing possible cases. And lastly, we are unsure about the contribution that azithromycin has to HS outcomes. We know that azithromycin has activity against ureaplasma. However, when it comes to mycoplasma, there is increasing resistance to that. So there is slightly some overlap for azithromycin. However, we are using pretty low doses since it's being used for BOS prophylaxis. So the take-home point of this research is that universal short-course fluoroquinolone prophylaxis may reduce the risk of donor-derived molecule infection, particularly in settings where donor screening is not feasible. Thank you all for listening. I will now take any questions at this time.
Thank you, Janae. I do have one question here for you. So is there a geographical variation in the prevalence of mycoplasma and ureaplasma that may impact the donor colonization risk?
Yeah, so we receive our lungs from all over the US. So definitely, I think you're going to see stuff kind of coming from everywhere. So as far as it being more prevalent in certain areas, we're receiving our lungs from everywhere. So this is something that would be universal that you need to prophylax against. We do have, like, kind of when looking at QTC here in Arizona, we do prophylax with fluconazole for coccidiomycosis, which is valley fever. So things like that, definitely we know can increase QTC and is more endemic to our area. But as far as molecules, no, that would be widespread.
Thank you. Does anybody else have additional questions? Okay, perfect. Well, we will move on then.
Yeah.
Thank you again. Oh, sorry, did somebody have a question? No. Okay. So we will move on. Thank you again, Janae. And then next we will be hearing from Shauna Katz, who is a PGY2 solid organ transplant pharmacy resident at the Duke University Hospital. I will turn it over to you.
Thank you, Samantha. Okay, there we go. Like Samantha said, my name is Shayna. I am the current transplant resident at Duke University Hospital in Durham, North Carolina. And my research project this year was comparing preemptive therapy with universal prophylaxis against CMV in intermediate risk heart transplant patients. Neither myself nor my co-investigators have anything to disclose for this presentation. Starting off with some background, I'm sure the majority of you here today are familiar with different approaches to CMV prophylaxis. But as a reminder, universal prophylaxis entails administering anti-CMV therapy to all at-risk patients for a defined period of time after transplant, while preemptive therapy involves not initiating CMV therapy until viral replication is detected. The recommended strategy for CMV prophylaxis depends on the patient, both the donor and the recipient serologies, and current AST guidelines recommend either universal prophylaxis or preemptive therapy for intermediate risk patients. Looking specifically at CMV in intermediate risk heart transplant patients, there was a study published in 2023 that looked at 563 CMV intermediate risk heart transplant recipients, and they found that compared with universal prophylaxis, preemptive therapy was associated with increased rates of CMV DNAemia and CMV-associated end organ dysfunction requiring the escalation of CMV therapy. It was also associated with increased hospitalization, acute cellular rejection, and detectable cardiac allograft vasculopathy. However, preemptive therapy was associated with lower rates of leukopenia, presumably due to less exposure to antivirals associated with leukopenia. Following the publication of this study, the Duke protocol for CMV prophylaxis in intermediate risk heart transplant recipients was modified from preemptive therapy with 3 months of valacyclovir in combination with weekly PCR monitoring to universal prophylaxis with valganciclovir or ganciclovir for 3 months after transplant. And the purpose of the present study was to assess the impact of this protocol change. Diving into the objectives of the study, our primary objective was to compare the incidence of CMV DNAemia that required either the initiation or escalation of anti-CMV therapy within 6 months post-transplant. We also compared the incidences of CMV syndrome or CMV tissue-invasive end organ disease, clinically significant leukopenia or neutropenia, and hospitalization for CMV. We looked to determine if CMV prophylactic strategy impacted patient and graft survival, graft dysfunction, and rejection of the heart transplant. And finally, we assessed adherence to weekly CMV PCRs in the patients in the preemptive therapy group and looked to see if there was any association between how far a patient lived from Duke and how adherent they were to the PCRs. This was a single-center retrospective cohort study conducted at a tertiary academic medical center, Duke University Hospital. We included patients who were transplanted between January 1st of 2022 and April 17th of 2025. Patients were identified using the UNOS database, and some information was collected through the database, and the remainder was via manual chart review. There were 2 different groups, the universal prophylaxis group, and we included all eligible patients for this group, while the preemptive therapy group, we selected a random sample of equal size. A brief overview of our statistical methods for this study. Descriptive statistics were used to summarize the patient demographics and clinical characteristics, and we used standardized mean differences to compare the groups. Gray's test was used to compare the primary outcome as well as clinically significant leukopenia or neutropenia, and death was considered a competing risk in patients censored at 6 months if neither death or the outcome occurred. We also conducted a multivariable subdistribution hazard model to examine the association between prophylactic strategy and CMV DNAemia, and potential confounders that we accounted for included induction type, donor CMV IgG serostatus, and rejection. All tests were two-sided with a pre-specified type 1 error of 0.05. For our patient population, these were adult heart transplant recipients at Duke University Hospital who were CMV IgG seropositive. We excluded any pregnant patients, those who underwent multi-organ transplant or a prior organ transplant, including a prior heart transplant, and we excluded any patients who received induction with antithymocyte globulin. For the patient enrollment, this just shows the breakdown of the screening and enrollment for the two groups. You can see the most common reason for being excluded was undergoing a multi-organ transplant. For the results, starting with our patient demographics, the average patient was a 53-year-old male, and there was a relatively even split between white and Black patients in each of the two groups. To help you interpret the table, standardized mean difference was used to compare the two groups, and anything greater than 0.2, is considered to be a notable difference between the two groups. That being said, BMI was considered significantly different between the two groups, with patients in the universal prophylaxis group having a slightly higher BMI than the preemptive therapy group. The majority of patients in both groups were transplanted for non-ischemic cardiomyopathy. Moving on to transplant characteristics, patients who received universal prophylaxis were more likely to have a DCD donor and receive steroid-only induction. And both of these differences make sense with changes in practice over time, with preemptive therapy changing to universal prophylaxis at the end of 2023. We've also seen a shift towards a greater utilization of DCD organs, as well as less basiliximab use and more steroid-only induction. Because valganciclovir dosing is something of interest to us, particularly as transplant pharmacists, we also wanted to assess the appropriateness of antiviral dosing throughout the 3 months of prophylaxis. Reassuringly, the vast majority of patients had their antiviral dosed appropriately for renal function, and patients were more likely to be overdosed with the valganciclovir or ganciclovir compared with underdosed for the renal function. For our primary endpoint, there was a statistically significant difference in the incidence of CMV DNA that required the initiation or escalation of anti-CMV therapy at 6 months post-transplant. And while this Kaplan-Meier curve looks very pretty, I do want to emphasize the fact that this was an expected finding. Based on the definitions of preemptive therapy and universal prophylaxis, we would expect patients who did not receive any anti-CMV therapy until they developed CMV DNA to have a higher incidence of CMV DNA. For the multivariable regression, looking at other factors, donor CMV IgG serostatus was the only covariate that was selected by backward elimination. Patients with a CMV positive donor were 4 times more likely to meet the primary outcome compared with patients who had a CMV negative donor. For the incidence of leukopenia or neutropenia, I've included here how we defined clinical significance. This was any leukopenia or neutropenia that resulted in either the administration of GCSF, a dose reduction in mycophenolate, premature discontinuation of the CMV prophylaxis, or a switch to alternative therapy such as letermovir. And you can see here that there was no statistically significant difference between the two groups in leukopenia or neutropenia at 6 months post-transplant. Other secondary endpoints, I know there's a lot here, so just to highlight a few things. Despite the difference in the incidence of CMV DNA between the two groups, there was no difference in patient or graft survival. Surprisingly, we saw a higher incidence of treated rejection in the universal prophylaxis group, which is different from the 2023 study I discussed earlier that found a greater incidence of rejection with preemptive therapy compared with universal prophylaxis. Finally, the adherence to weekly PCRs was very low in the preemptive therapy group, which makes you question if we were underestimating the true rate of CMV DNA, and this could have been even higher than we found in the study given the low adherence rates. Moving on to the discussion, we saw an increased incidence in CMV anemia with preemptive therapy. However, this does reflect the intention of the prophylactic strategies. Having a CMV IgG positive donor was a significant risk factor for CMV anemia, which is consistent with findings in the prior study in CMV recipient positive heart transplant recipients. Despite both CMV positive and CMV negative positive pairings being classified as intermediate risk, those with a donor who is positive for CMV may have a higher inherent risk for CMV complications compared to those with a negative donor. We did see a similar incidence of leukopenia and neutropenia in the study, regardless of the prophylactic approach. And unfortunately, given that we only looked up to 6 months post-transplant, we were unable to assess the impact of CMV prophylaxis on the development of cardiac allograft vasculopathy, which CMV is known to be a risk factor for. Some strengths of the study is that we assessed the impact of an institutional protocol change and conducted multivariable modeling. In terms of limitations, this was a single center retrospective study design, and the duration of follow-up after transplant, like I mentioned, was limited to 6 months. I won't read through all of the conclusions here, but the big takeaways from this is that the switch from preemptive therapy to universal prophylaxis has been helpful in preventing the incidence of CMV anemia in our patients, and it doesn't appear to be associated with an increased risk for leukopenia or neutropenia. Most importantly, I would say we need to reevaluate the impact of the protocol change in a few years to allow for more time to pass, and this would also allow us to include other endpoints such as CAV. I'd like to thank my project preceptors and co-investigators, as well as the statisticians on the project, and I'm now happy to take any questions.
Thank you, Shauna. I do have one question here for you. It said, based on your results, do you think universal prophylaxis should be preferred in this population, or would either strategy be appropriate?
I think based on the results of this study, universal prophylaxis appears to still be preferred. We didn't see a major difference in any of the other endpoints between the two groups in terms of rejection or hospitalization, but given the lower incidence of CMV anemia that required some sort of escalation in therapy, I think that universal prophylaxis would be preferred to prevent any other CMV complications from occurring, maybe ones that we did not capture in the limited duration of follow-up of the study.
Thank you. Does anybody have any additional questions for Shauna? Okay, sounds good. Well, with that being said, we are now going to hear from Dawson Green, which is a PGI-1 resident at Virginia Mason Medical Center.
Alrighty, thank you for the introduction. So my project's going to be a little different than some of the other ones. It's going to go a little less clinical and more of the value that a pharmacist is contributing on a transplant service line. Okay, so I have nothing to disclose, and yeah. So here are my learning objectives. If you want to take a quick, brief look over them. Alrighty. So my institution is a hospital in Seattle, and it's a part of the Greater Virginia Mason Franciscan Health, which is a part of Common Spirit. We always have one transplant pharmacist on service 7 days a week, And there are 3 floors of a 336-bed hospital that they are covering. These are transplant patients and also non-transplant patients. And of note, we only do kidney transplants here. Okay, so here's some pre-test questions for your leisure as well. Alrighty. So some background of this study and why we were doing it. So we lack sufficient financial support or data to support pharmacy service lines at Virginia Mason Franciscan Health. And these are not just transplant services, but other services as well. One thing to note is that regulatory requirements from CMS and UNOS do require a transplant pharmacist for accreditation. But something those organizations don't do is define what qualifications are deemed to serve in a transplant program. So that's kind of part of what we wanted to do with this study as well. And so the main purpose was to measure and show the value that transplant pharmacists are doing at Virginia Mason. So my methods were step one was to define and measure different tasks that the pharmacists were doing on the transplant service related to the transplant patients who are being actively transplanted, as well as the patients who are readmitted, as well as their non-transplant patients on their floors. Step two was to look over the stats on some of the numbers, how many transplants we had in a year, average length of stay of these patients, and how much they were readmitted. We also took into account the salaries of the professionals. So these would be nephrologists and the pharmacist. Step three was a literature review. So going back into some of the literature I was delving into in the beginning, and we would determine which tasks in the literature were kind of showing some financial value, and that would deem which task we used in our return on investment calculation. And then finally, the calculations themselves were done to see cost prevention in various different ways, and we'll get into that. So some of the statistical collection in the last fiscal year of 2025, we had 97 kidney transplant patients. Their average length of stay, and all of these averages are means, was 4.4 days for active transplant patients, and then their readmission rate was about 23, almost 24%, so 23 of the 97 patients. Hospitalization and readmission costs. Their average length of stay, if they were readmitted, was about 6.17 days. And this was on ICU and medicine floors. And that'll come into play in a little bit, but the cost per day for each of those floor on average is listed there. So the 4,500 for ICU and then 1,500 for the medicine floors. And then we also took into account the professional salaries per hour. So pharmacist here, 86, and then nephrologists earn 196. And so this little review here is going to go over some of the charts that I have on the next slide. So this is just a brief overview, but I also have it here for you guys as well. So I spent 3 different days looking at the pharmacists and what they did on their service line as a transplant pharmacist, and I wanted to document what those days looked like. So it could vary depending on the day, depending on if we have active transplant patients or not. So this was an example of a day where there was 3 active transplant patients and a student, which would be considered a pretty busy day for the transplant service line, along with their other patients that they're taking care of besides the transplant patients. One thing to note of this, so what was deemed not to be a financial outcome are tasks that are in purple, pink, and orange. So these would be quality patient care acts, documentation, as well as administrative tasks. And a full breakdown is on the right here as well. Okay. And then here's another day if we want to take a look. So 1 active transplant patient and then 1 discharge. And the reason I separate the discharge from the active patients was because the discharge tasks kind of accumulate a larger pool of tasks whenever there is a discharge patient, and that's the brown here. And then we also have the green. And so these two are education, and then as well as our discharge education, as well as setting up patients for transition to the outside of the hospital. So setting up their pharmacy, making sure they're getting their meds, making sure they're well educated to go out. So these two were deemed to be transplant patient specific tasks, which will come into play when we're calculating our ROI. And then every other task was deemed to be a just task that wasn't transplant patient specific. And then here's another day, if you want to just take a look at kind of the distribution of how pharmacists spend their day. Okay, so moving on to the average time of the active transplant patient specific tasks. Here's a list of those tasks and how long on average they took. So, for example, patient education over the 5 patients that I looked at or monitored pharmacists looking at over the past few days or the 3 days I monitored them, it was about 24 minutes for patient education on average. And then if we take all of these averages, add them up, and then multiply them by our 97 patients that we see, what we saw in the past year, we can get about a 163-hour time that we can assume was used for transplant patient-specific tasks. So moving on into the calculations portion. So this is specifically the active transplant patient tasks. And if we take that time and we multiply it by the amount a pharmacist makes and the amount a nephrologist makes per hour, we get these two numbers here, the 32,000 and the 14,000. And then we can look at that and see that because pharmacists do make less, we can see that pharmacist time saved about almost $18,000. And then moving on. So then these are the non-transplant patient specific tasks. So these would be things that patients or pharmacists could be doing on transplant patients as well as the other patients on their floor. So on average, these tasks were looked at over 365 days. So we measured them over 3 days, but then we took the averages, and added them up through the 365-day period, and then the tasks were averaged over the 3 days, if that makes sense as well. And that number came out to be 1,151 hours, and then that task time was averaged again and then times by the 365 days. And then this is the calculations we got for that time. So for the pharmacist, we got about 99,000, and then for the physician or the nephrologist, we got about 225,000, saving us about 126. And now, the bigger part of the study that I think was the most important was looking at this average length of stay or avoided readmissions mainly. So 6.17 days is the average readmission or length of stay of transplant patients in the fiscal year of 2025. And this is kind of a minimum estimate of how much was saved by preventing readmission. So the 6.17 days times how much a medicine floor costs is about $9,600. We take the amount of days that the patients were readmitted for on average, and then multiply that by the patients who weren't readmitted, and we get about this many days, the 456 days. Multiplying that by the 1,500 for a medicine floor, we get about $711,000 saved by preventing these readmissions. Now, one thing to note is that this is the medicine floor only and not the ICU. So this is a generous amount, and saying how much we're saving, it could potentially be more if we took into account the ICU. So adding all that up, we get about $855,000 saved, which is a 1-to-5 efficiency ratio. So for every $1 spent on a pharmacist, $5 is saved for the institution. And then on a calculations basis, we use the pharmacist salary of $180,000 per year, or $86.54. Some discussion at some of the studies I was looking at as well. So there was this one study that was looking at the length of stay and the impact it had, or the pharmacist impact it had on the length of stay. So Maldonado et al. 2013 showed a very significant reduction. So it looked at a pharmacy service line or a transplant service line without a pharmacist and then with a pharmacist. So it looked at it in 2 different years pretty much. And length of stay went from 7.8 days to 3.4 days with pharmacist interventions, education, and the impact of a pharmacist alone. VMMC's performance is about 4.4 days with a pharmacist. So if we take that on average, and kind of extrapolate that. So we take the 7.8 minus the 4.4, and then we look at that time saved. It would be about $5,297. So that would be per the medicine floor, a time that was prevented by the length of stay. And then we multiply that by the 97, we would get the $513,000 saved. Now, this can't be fully extrapolated again because it is from a different study, but it's just something to note that pharmacists are making an impact on length of stay, and it shows at Virginia Mason as well. So some limitations of this study. The sample size was relatively small. I was only able to shadow pharmacists for 3 days to collect time studies. It would be more beneficial to see a pharmacist over a longer period of time to see days they weren't as busy with active transplant patients. Where was their time being allocated? Compensation data was again averaged and not individualized per professional. So we did take the average nephrologist salary, the average pharmacist salary, but again, there are benefits, and depending on how long you've been at the institution, you could be getting paid more. There is also observer bias, so potential for me for mistiming something when I was timing them, as well as potentially miscategorizing something as well. And then the cost analysis as well is limited due to the time frame data. And then there's also a literature gap, being that there isn't a lot of return on investment studies for a transplant pharmacist. So my conclusions are that transplant pharmacists are making meaningful and valuable financial contributions to our system. And then some metrics to implement in the future are to recommend to capture the pharmacist interventions consistently through formal metrics, rather than do these simple time studies, but have a way to actually capture the interventions they're making and able to do a better study the next time. And so the human element of this is also something I think is important, to remember that there is that human element that we can't fully replace. So there might not be always that impact on financial outcomes or clinical outcomes, but it's about the patient experience as well. And that's what I captured in one of the time study pieces that I collected with the Quality Patient Care Acts. So things I witnessed pharmacists doing, going above and beyond for their patients, I thought was something important to include, and remember that that is a true part of healthcare and a true part of a transplant service as well. So thank you for your time. Here are the answers to those pre-test questions. And yeah, any questions?
Here is one question for you.
Okay.
And that question is, are there any tasks you feel should be more highly prioritized or alternatively deprioritized for a pharmacist FTE to be optimized to best optimize ROI?
Yeah, no. I definitely think there is some room for improvement or for some more task allocation. Um, I I think it's not always, you're not always able to look at the other patients. So our transplant service line doesn't just look at the transplant patients. We also have neuro patients on our neuro floor that we look at, and then a few other patients on other medicine floors. And on days those we have busy active transplant patients, or like a lot of active transplant patients, it would be very important to kind of allocate that work on those other floors to another pharmacist, or potentially have a part-time role to cover those positions as well, because those patients aren't fully getting looked at, and there are potentially things being missed because they don't have enough time to allocate to these patients. So I think that would be my suggestion for the institution.
Perfect. Thank you. We are at time. So again, on behalf of the ACCP Transplant PRN as well as the AST Transplant COP, thank you for joining our second annual resident research webinar. And a special thank you to our residents for presenting their research today. Just as a reminder, all attendees will receive an email after the webinar with instructions for obtaining CE credit. We also have 2 additional webinars scheduled, so we hope to see you next week at our next webinar. Thank you everybody again for joining, and enjoy the rest of your day.